Perfect. Full screen and laser pointer.
Just okay, right. So I'll just adjust.
Yeah, click on the right side of the mouse.
Okay. Yeah. Okay. So good evening, everybody. This is Kedar Deodhar from Mumbai, and I welcome you all. Let us start with the GI path. Am I Sumit? Am I audible? Okay.
Perfect.
Yeah, and we can see the screens. Yeah.
Yes. Perfect.
So this is a talk on histology and gross examination of stomach, gallbladder, and colorectum. Because I was wondering with myself, which organs shall we start with grossing? And fortunately for me, the Whipple surgery grossing was coming out to be normal, to be a longer slide presentation. But fortunately for all of us, next week we have Dr. Annie from Washington University, who will be covering on pancreatic grossing. So I will confine myself to stomach, gallbladder, and colorectum. We do work with cancer, so to some extent these are tilted towards the cancer specimen grossing. So some short time in histology of. Okay, so a little bit on histology, and then we'll move on to the grossing. So conflict of interest, none. I've used some diagrams and cartoons, but wherever they are used, I've referenced them, and they are for educational purpose only. So how we will arrange the talk is that we'll have histology of stomach, a few slides, histology of small intestine, including a duodenum. We'll have histology of colon. And I'll mention briefly, we'll see the normal pattern and maybe give some comments as to, in our routine practice, what is the things that we face when we are looking at the normal and we are reading what is normal and what is the difference between normal and abnormal. Then we look at gross examination of stomach, gallbladder, colorectum. I'll spend a little more time on colorectum because those are relatively common specimen for us, and we won't be covering Whipple's surgery today. I also am not covering actually Barrett's esophagus because this has been taken, and I'm sure this will be taken by one of the experts later on in the talk. So if we were to look at if we look at in general the GI tract or bowel organs, we basically have four layers: mucosa, submucosa, muscularis propria, and serosa. Mucosa is composed of epithelium. The connective tissue around the epithelium or crypts is lamina propria and muscularis mucosa, which is a component of the mucosa, and then comes submucosa, then comes muscle coat, and then comes the serosa. So this is an example of a gastric histology. We are looking at the mucosa here. We're looking at the muscularis mucosa here, submucosa, and the muscle coat, muscularis propria. These are the gastric glands. Gastric glands are seen in generally the body part of the stomach, not so much in the cardia or the distal antrum of the stomach. But gastric glands are composed of chief cells and oxyntic cells. So basically, acid-producing cells and exocrine cells which secrete pepsinogen. Acid-producing cells, mind you, also secrete what we call as an intrinsic factor of the Castle's intrinsic factor, which is responsible for B12, vitamin B12 absorption. So just a little bit, because we don't, to be honest, we don't look at too much into the mucin histochemistry these days. Because many of us use immunohistochemistry, but mucin histochemistry is actually fascinating. And if we try to do that, some of the experts do use mucin histochemistry to diagnose intestinal metaplasia and so on and so forth. But to look at the mucin histochemistry, the normal gastric mucin is actually neutral mucin, and that is seen in stomach, many other parts of GIT, and also in prostate. Which is PAS, positive periodic acid shift positive. And Alcian blue normally stains actually the acidic type of mucin. The gastric normal mucin is neutral mucin. So Alcian blue normally is negative in the gastric mucosa. I must accept, and I must thank Dr. Lakshmi Narayan, who was our former colleague at Tata Hospital, a very learned man, and he is now currently based in Kochi. I borrowed these slides from Dr. Lakshmi Narayan, And I'm thankful to him, I'm grateful to him. So if we were to look at gastric mucosa, which is showing intestinal metaplasia, and by that we mean either it could be complete or incomplete. Complete meaning all the crypts of Leberkuhn or cell organs may be present in that particular given area of, and then we call it complete intestinal metaplasia. But otherwise, what we are looking for mainly are actually goblet cells. And goblet cells are routinely stained by Alcian blue at pH 2.5. So they are actually one of the acidic type of mucins, and they are seen in intestinal metaplasia. On the right side, we look at these things, and what we know from the mucin histochemistry is that Alcian blue routinely at pH 2.5 stains both sialomucins and sulfated mucins. These both types of mucin are actually types of acidic mucins, and only the latter, meaning the sulfated mucins, are stained at pH 1. So if we were to do, and the sulfated mucins are the ones which have kind of a bad connotation, because they are the ones which are usually seen in this type of mucin is seen in carcinomas and dysplasias. So high iron diamine is one of the histochemical stains. Some of the experts who are relatively senior would have worked with this, but the younger colleagues may not have worked with this. HID stains sulfated mucin. So if we were to treat HID and then use Alcian blue at pH 2.5, we can actually stain both the types of mucin, which is sialomucin and sulfated mucin. So these are examples from Dr. Lakshmi Narayan's actually from collection. On the left side, we can see these blue points, which are the goblet cells, in telling us that there is intestinal metaplasia. These will be the same. The sulfated mucins with high endiamine actually are stained actually brownish in tinge. So these are some of the examples of sulfated mucin staining with high diamine. They are types of acidic mucin, and although we don't use it normally, the connotation is that they are part of they are seen in usually dysplasia or adenocarcinomas. Again, example of HID Alcian blue staining. Normal gastric mucosa will not be showing Alcian blue, but when it shows, it means that there is intestinal metaplasia. And HID positivity, such as brownish or blackish stain here, tells that we also have sulfated mucin in this type of intestinal metaplasia. So coming to actually, general comments when we look at gastric biopsies, but whenever we have a biopsy, we try to assess the location by looking at the gastric. Are we seeing gastric glands such as chief cells and oxyntic cells, or are we looking at only foveolar cells or antral type epithelium, which are mucin producing cells? So in a given, even if the endoscopist does not tell you which part of the stomach the biopsy is derived from, we should be looking for at least from the constituents of the biopsy, whether it is from the body or the antrum. If neutrophils are seen, look hard for H. pylori, because that is actually the dictum. H. pylori accompany the neutrophils or active inflammation. The experts believe that if we look at H. pylori, we don't find H. pylori, and we have a lot of active inflammation, then that may be the case of Crohn's disease. Just keep it at the back of your mind. Crohn's disease we are used to see or diagnose in the colon, but Crohn's disease can affect entire part of the GI tract, including perianal skin. And in stomach, neutrophils without H. pylori, that may indicate or that may raise a possibility of Crohn's disease. Just keep it at the back of your mind. Generally, in ulceration areas, if we have atypical cells, be very cautious in diagnosing dysplasia or a high-grade dysplasia, because ulceration can induce different types of metaplasia or reactive change, and that's time we should be cautious, think twice before calling it dysplasia. If we have mucosal prolapse changes, these are the ones usually endoscopists can tell us that they are seeing actually either bile reflux at the time of endoscopy, or if there's any look for any chronic NSAID usage. And these are the mucosal prolapse changes. This is the same changes. These are the same changes that we see in solitary rectal ulcer syndrome. So these are the etiological factors in gastric mucosa. Another point, maybe a little bit of practical point, is that if you have severely dysplastic cells and which are very few in number or scanty, it's better to ask for repeat biopsy, because usually such cases, especially high stage disease, are going to go for pre-operative chemotherapy. And sometimes, in few cases, it so happens that the chemotherapy gives complete response, and we don't know whether we are sure of the invasive cancer or no. Secondly, if you're trying to drag ourselves to call cancer, and we suppose we indeed call it a cancer, we may get MMR, immunohistochemistry, or HER2 immunohistochemistry request to call, to give the results on that, especially gastric biopsy. And then we may not have enough cells, then we are struggling to give, other immunohistochemistry results based on that particular smaller sample. So it is okay to ask for repeat biopsy for better representation. And this is actually mentioned in one of the CAP guidelines, that better to have a better biopsy, confirmed biopsy, and then actually give the diagnosis, because those are the ones, or many times they will go for pre-operative chemotherapy. And it is okay to use IHC. It's my personal belief that it is okay to use IHC to confirm poorly differentiated adenocarcinoma or poorly cohesive adenocarcinoma, as we see in signet ring adenocarcinoma. Coming to a little bit of small intestine, the normal part, again, it has mucosa, submucosa, muscularis propria, and serosa. The mucosa again contains epithelium, lamina propria, and it's projected into the lumen as villi, and they have crypts of Leberkuhn that extend to the muscularis mucosa. Villi are shorter in the duodenum, duodenal bulb, and the Brunner's glands are abundant. Brunner glands are tallest in the distal duodenum and proximal jejunum, and they are shorter or thinner in the terminal ileum. They are progressive towards the terminal ileum. Generally, it is mentioned that Brunner glands are seen in the submucosa, but in practical or reality, you may see them in the deeper part of the mucosa, and that's normal for Brunner's gland. These are the examples of Brunner's gland. We see those as mucin-containing globules of cells. Very, very rarely we will have a tumor nodule which is formed by either hyperplasia or what is described as hematoma, or you could debate it as an adenoma of the Brunner gland, but that is a very rare occurrence. It can, generally the Brunner's gland hyperplasia or hyperplastic change can impart nodularity to the endoscopist, and it may look like a small raised nodules as neoplasm. These are the same appearances on endoscopy with neuroendocrine small tumors or tumorlets. So just remember that Brunner gland hyperplasia may be seen on endoscopy as a fine nodularity. Coming to small intestine normal epithelium, we have basically 4 types of cells: enterocytes, goblet cells, Paneth cells, and endocrine cells. The enterocytes are the absorptive cells. The epithelium normally contains scattered T lymphocytes. These are expressed by CD3, CD5, and CD8. These are and this is where we look for intraepithelial lymphocytes. The number up to 20 per 100 enterocytes is considered normal. And in celiac disease or any other related diseases, we are looking for increase in intraepithelial lymphocytes, which are the T cells. Some of the rare variety of T cell lymphomas are the ones which are seen in the small intestine or jejunal or the terminal ileum area. So goblet cells contain mucin, and they are the ones which, as we discussed earlier, they are the ones which contain sialomucin, and these are the ones which are Hessian blue positive cases. They also express mucin core protein 2, and this is the one where we use MUC2 immunohistochemistry antibody. I think the Paneth cells are one of the most curious cells in small intestine. We don't really know exactly their function, but they are basally situated. They have basally situated nuclei. We can identify them with suprabasal large eosinophilic granules, and they are rich in growth factors and antimicrobial proteins. So they are the ones which is any chronic injury, we will see Paneth cells. So these are the ones. In chronic inflammatory bowel disease, in especially left side of colon, we look for Paneth cell metaplasia, because these are the ones body tries to kind of give a repair response with growth factors and antimicrobial proteins. They are normal in small intestine. They are normal probably in the proximal part of the ascending colon, but they are not normal in left side of the colon. So that's a curious and interesting cells. We also have endocrine cells, which have infrabasal small granules, and they are finer granules. These are the part of the crypts of Leberkuhn. So these are the examples of the crypts of Leberkuhn. If you go on higher level, these are the cells. These are we have nuclei basally, and we have suprabasal coarse granules. These are the Paneth cells. And we have maybe these are the endocrine cells, which are part of the crypts. Endocrine cells usually will have a very fine eosinophilic granules, which are in the lower part of the cytoplasm. So regarding general comments, we did center that Brunner's glands or gastric glands are useful in confirming the location of the primary site of the biopsy, because they are the ones, even if the endoscopist does not tell you, we know this is the location, either duodenum or the stomach. Villi in the first part of duodenum are shorter. So that does not mean, we usually look for evidence of celiac disease when the villus blunting is seen in reading the slides. But in the first part of duodenum are usually shorter. So do not read first part of duodenum for celiac disease. We should usually read the second or third part of the duodenum for blunting of villi. H. pylori are unlikely to be seen in alkaline environment, but do look for them as a matter of habit. And as a matter of habit, also look for giardia. Giardia is one of the uncommon protozoal infection that we see commonly, or it can usually be seen in duodenum. But if you have the habit, then we will remember it. Otherwise, we'll forget looking for giardia. All intestinal biopsies, I think, is a good practice to be read with step cuts, because we can, especially in the ileocecal region, because we can miss a small granuloma, and if we have step cuts, we can pick up small granulomas in this location. Again, Paneth cells are normal in small intestine and to some extent proximal right colon, and their presence in the left colon is important to assess chronic inflammatory bowel disease. One more point is that chronic inflammatory bowel disease may simulate immunotherapy-related colitis. So if this particular history is very important. With the advent and use of immunotherapy in cancer, we are seeing these changes more often currently for last 4 to 5 years. They can give rise to architectural distortion, cryptitis, cryptabscess. They can show apoptosis also, and these are the same features that we are assessed in GVHD or graft-versus-host disease. So the history is important, and the knowledge that immunotherapy can simulate or can look like chronic inflammatory bowel disease is important. So the duration of the illness is actually is crucial in this part. And as a matter of habit, if you are reading any colonic biopsy, I think it's a good practice to look for with architecture or other inflammatory component in the lamina propria. Look for CMV also in endothelial cells and fibroblasts. That will be a good practice. So in normal colon, we do have the mucosa, which is about test tube. It's typically described as test tube-like features. They are arranged parallel to each other, the crypts, and this is actually the normal appearance. When it is disturbed or we have bifid or branch crypts, then we call it architectural distortion. Normally, colon will have a lymphoid follicle. So when we have a small lymphoid follicle, there is a small elevation here. It's like we draw a line here. There will be a small elevation in this area, and then it dips down here. So this is a normal feature of the colon. This actually will be a normal feature in stomach also, and this also, to be honest, as a small lymphoid follicle will be normally seen in endometrium also. So this just a finding of a small follicle which could have a germinal center does not make it a chronic inflammation of the colon. This would be normal, and the way to identify is that there will be small elevation of the normal mucosal area with that. If we compare with the adjacent mucosa and there's no basal plasmacytosis, this is to be taken as normal feature and not a feature of chronic inflammation. Coming to a difference between right side colon and left colon, by and large, right colon will have a more amount of inflammatory cells, and again, this will be taken as a normal component in especially ileocecal region. This may be taken as normal. This we don't call it chronic inflammation. We see if you have basal plasma cell, then that is significant. But lymphocytes, somewhat more in number, does not mean that this actually signifies chronic inflammation. On the left colon, on the other hand, the number of inflammatory cell component is actually lesser in number. So with that, the short histology matters will go on to the grossing matters, and we'll deal with about 3 organs: stomach, gallbladder, and colorectum. I'll take maybe slightly longer time for the colorectum. So basically what we are looking for is a comprehensive pathology report when we are looking at a specimen which is resected for cancer. And what we are looking for is to confirm the cancer diagnosis, which was offered preoperatively. We inform the prognosis by getting TNM stage. And all our grossing techniques, guidelines are basically in order to give as accurate TNM staging as possible. By that we mean tumor, node, and metastasis. So to say, in the given specimen, maybe APR or stomach or mandibulectomy or mastectomy, the metastatectomy may not be with us, but we have to be as accurate as possible regarding T stage and N stage as regards to our cancer pathology report. Also, the margins and other adverse prognostic features. Commonly, by that we mean lymphovascular emboli, sometimes perineural invasion, margin positivity, and so on and so forth. This also is very useful for any institution audit pathology services, because this is one, if you have a bigger department, we have several hundred reports being generated every month or every year. It also gives us a chance to see what should be going into the report, and are we complying with that report. That gives us a chance to audit our own services or practice as compared with the standard prescribed gold standard. It also helps us audit other services such as surgery or radiology, because by that I mean a good APR surgery and good pathology assessment tells us, can also, we can compare it with CT scan reports or MRI reports, and if the radiologist has mentioned that significant positive node, you can actually have a correlation with radiology with that. It also collects accurate data for cancer registry and cancer epidemiology, and also facilitates research. This can be a good set for MD student thesis or dissertations. So in a general pro forma cancer reporting, we look at what is operative procedure, the gross description, tumor size, histological tumor type, differentiation or the grade of the tumor, extent of the local tumor state. By that we mean T stage, LVI, lymphovascular invasion, perineural invasion, lymph nodes, as many nodes as possible, how many are metastatic and how many are reactive, margins, treatment effect in a specimen where patient has received preoperative chemotherapy, radiation therapy, and of course the staging. So some of the descriptors, as P stage, we call it pathological. When we give TNM stage, we call it PTNM. When we call it Y, this is when the preoperative chemo radiation has been given. So we call it Y, PT, 3N0, or something like that. R is a recurrent disease. M is the presence of multiple primaries, and A is determined at autopsy. To be honest, we do very few autopsies nowadays, very uncommon now. So to give a diagnosis, so TNM descriptor at autopsy is rather not common. We have cancer data sets given by various international reputed societies, such as College of American Pathologists or CAP, Royal College of Pathologists of UK or FRCPath, and what is called as International Collaboration on Cancer Reporting or ICCR. This is a collaboration of many international experts, not only pertaining to one country. And ICCR gives us what is core and what is non-core data items. This is based on the evidence that evidence-based medicine. And I just want to introduce, and most of the PGs and most of the staff is familiar with that. So there are certain things which are mandatory, certain things which can add value, but they are not mandatory. So that's what we mean by core and non-core data items. So coming to a gastrectomy specimen, we can have a gastric cancer resection specimen. It could be partial gastrectomy, which could be proximal gastrectomy. It could be distal, subtotal, total, or wedge resection, usually for GIST or small tumors such as neuroendocrine tumors, or we could have endoscopic resection. And this is what I mean by core data items. So such as tumor type, tumor site, tumor dimension, tumor grade, LVI, margins, lymph nodes, TNM stage are the core items. For clinical information in our report, specimen dimensions, microscopy of the tumor types, such as ulcerated type, also infiltrative type, or cauliflower type growth. Perineural invasion currently is non-core in many data sets, or coexistent pathology is non-core. So this is what we mean by core and non-core. And for different organs, it may vary slightly, but the idea is to introduce the concept of core and non-core data items. By that we mean what is mandatory and what is not. I mean, what must be stated in the report, or what may or may not be included in the report. Coming to carcinoma stomach, this is actually given in textbooks and in variety of data sets. We need not go into details of all these slides. PT1 usually is to mucosa. PT2 is usually muscularis propria, mucosal involvement, and PT1 is mucosa and submucosa actually, sorry. PT2 muscularis propria, PT3 is subserosa, and PT4 is a serosa involvement, PT4 is serosa, and PT4B is adjacent structures. Generally, now we see that early gastric cancers are removed surgically per primum, but anything more than PT2 or more will receive actually preoperative chemotherapy or perioperative chemotherapy, and then we get the specimen. That's why we look at the specimen which is post-chemotherapy to us. So this is PT1, mucosa and submucosa, PT2 involvement of the muscularis propria, PT3 is subserosa, and we have PT4, which is a serosal involvement. So by and large, what we are seeing in last 7 to 10 years is that except for PT or very early gastric cancers, most gastric cancers will receive perioperative or preoperative chemotherapy and then will come on the crossing table. As regards to method of opening the given specimen, usually we open on the greater curvature. Exception is that if we have a tumor mentioned on the greater curvature, we'll open on the other side on the lesser curvature. Try to look at the tumor, measure the tumor, whether fundus, body, or antrum. We'll see anterior wall, posterior wall. We note the size and the size. Of course, we will look at the margins, proximal and distal resection margins. So this is how we will try to take multiple sections. And if we have a well-fixed specimen, do open it and keep it overnight, or at least overnight, but if possible 24 hours. And this gives us a good hardened area, and with a sharp knife, we can take these sections, and these are the ones we can lay it on the table, and these are the ones which shows the maximum depth of infiltration. These are the ones which we are assessing, taking into the filling up the cassette. So ulcerated tumor here, and what we are also looking at, we have the rugal folds. Rugal folds stop at the tumor area, and this is the one good clue for the grossing. If you have an ulcerated tumor, this is the area which we have to sample extensively. Also take one more section from the normal looking area to look at any other pathology or any other atrophy or such changes or the other, so on and so forth. So sections, usually we take 3 to 4 sections from the tumor. We take the margins, we take at least one section from the adjacent stomach, and we look at lymph nodes as received. So, sometimes or often we will look at omentum in 3 to 4 sections from the omentum, if the omentum is obviously or grossly normal. But whereas if it's obviously metastatic deposit, and 2 sections from the metastatic deposit should be okay. Margin, if the close, we take the radial margin, but if the margins are far away, the shear margin is sufficient. Positive resection margins have adverse prognostic implications, and revision of the margin is to be considered. This is where our role in frozen section will come in handy. This is a specimen of a carcinoma stomach, but which is after resection, resected after chemotherapy. So we don't really actually see any tumor. So here we are actually just seeing a plaque-like area or area of thickening, and this is perhaps best judged with palpation. So palpation is crucial, especially in the post-chemotherapy area. So we will see an area which is loss of rugal folds. So this is normal. This is an abnormal area. Paler area, which will show, if you palpate, which will show thickening or plaque-like area. And this is the area I will take maximum number of sections to see whether there is any complete tumor response or partial response. So again, this is the area of a proximal stomach ulcerated area. So we'll take sections from these areas, 3 or 4 sections, and so on and so forth. Again, a higher power area of ulcerated area, which is post-chemotherapy. This is the area where there's no rugal fold, there's some congestion. It could be paler or it could be congested, but this is an area which if you can see this thickened area here, that's the area which is most suspicious, which can show tumor or which can show us a complete fibrotic response post-chemotherapy. So again, esophagus, part of esophagus, and this is the stomach. And we see an area. So I'm trying to show you pictures which are mostly post-chemotherapy, because this is the tumor is not obvious, but this is the area, and careful gross examination tells us that where are we sampling the area from. So coming to end stage, basically we want to dissect as many nodes as possible. We have definitions given in textbooks. What is N1, N2, and N3, depending on the number of nodes. Usually perigastric nodes are resected, and we have surgical guidelines. Actually, the perigastric nodes are called as D1 resection. Slightly higher nodes along the blood vessels are surgically called as D2 resection, and extensive lymph node dissection is called as D3 resection. The standard D1 is actually right cardiac along the greater or lesser curvature in supra and infrapyloric nodes. D2 dissection, additional removal, as I said, along the gastric artery, common hepatic artery, and so on. And this is the surgical standard. So any institution doing cancer stomach surgery, they should provide us with D2 dissection, and D2 dissection should be attempted by the surgeon, oncosurgeon, and that's when we get these. I think I'm looking at some questions, so maybe we'll answer the questions later on. Let me go on with the presentation first. So it is suggested in stomach is that at least 16 or 15, 16 regional nodes to be removed. But removal or evaluation of more nodes, such as 30 or more, is desirable. Involvement of other group of nodes, which are para-aortic or peripancreatic nodes, are not considered regional nodes, and they are regarded as M1 disease. So D3 is more extensive lymph node dissection. This can give rise to a lot of morbidity post-operatively. So, but surgical standard is that D2 resection should be done. So cancer not staged using this particular system are the GIST, because this particular system, TNM stage, is usually looked for lymphomas. So sarcomas, lymphomas, so you look for usually done for carcinomas. For GIST, lymphomas and sarcomas, and NET is slightly different. NET is similar, but I'll point out in a minute what is the difference between NET. So lymphomas, obviously, we are not going to get tested. We are very, very uncommon to get actually organ resection if we have an established diagnosis of NHL or Hodgkin's lymphoma. Coming to response to neoadjuvant therapy, it is usually it is to be given whether we have complete response or partial response, and we have different stage difference tumor regression grading scoring system, which is Mandard or modified Ryan and so on and so forth. If we see only acellular mucin, that is taken as complete response, and that is not taken as a residual tumor. So we have this is a tumor regression grading 5-tier, which is Mandard, which is called as Mandard scoring system. This was actually used first in esophageal cancer. So we still use this 5-grade system, which is grade 1 is actually no cancer cells, grade 2 scanty cells, and grade 5 actually complete. I mean, there's no fibrosis, no response to chemotherapy, and extensive residual cancer present in grade 5. But CAP tells us or recommends a 4-point scoring system, or modified Ryan system should be okay. A 3-point system, sometimes some people use 1, 2, and 3, or some people use 0 is complete response, and 1, 2, 3 are the other 3 being the poor response, and that's okay. Whatever you use, I think that should be very clear to your treating medical oncologists and surgical colleagues, and there should be uniformity whatever we are using, and that's our goal. So uniformity by different pathology consultants in reporting the response, and that's just a minute. Okay, so that's that. So neuroendocrine tumor, T1 stage is the same, but T2 tumors that invades the muscularis propria. But the only difference is that a tumor in mucosa and submucosa, which is more than 1 centimeter in size, is called as T2 tumor in neuroendocrine tumor. So I think we can skip this slide. This is the summary of the changes between the 7th classification and 8th classification in stomach. So to conclude regarding the stomach grossing, we have diligent grossing is important. Probably this slide is common for all grossing. Lymph node retrieval as many as possible. Diligent grossing is important. We have a slide, some people might ask, do you use fat dissolving techniques such as xylene or chloroform? So the practical answer is that careful palpation is actually the key. We can use fat dissolving technique, but it is in a high volume center. It is actually not feasible or practical to actually use that. For stomach D2 lymphadenectomy, the surgical standard, the specimen are likely to be post chemotherapy. So therapy response grading is to be given, and palpation and induration or loss of rugae I personally have found to be most useful in potential tumor localization. So use data sets, whatever you use, you can devise your own system based on FRCPath or CAP or ICCR data sets. Going on to gallbladder, we have gallbladder cancer resection and we have APR resection. So gallbladder, the standard sections for non-neoplastic lesions, this is a common specimen, laparoscopic or open cholecystectomy, but mostly nowadays are laparoscopic. And usually for chronic inflammation or calculi, and we take generally 3 sections, fundus, body, and the neck area. If there is undue thickening, then please obtain more sampling, which is good area to take cystic duct cut margin in the first instance, because if you incidentally detect any cancer, the better to have cystic duct cut margin blocked first, so that there's no chance of carryover, tumor carryover in cystic duct margin area. So scenarios for surgical pathologists in gallbladder malignancies is that either we face incidentally detected gallbladder cancer, or we look at a radical cholecystectomy, which there is a fair amount of suspicion of malignancy on the radiology, and that's why we receive not only gallbladder but also the local nodes and a part of the liver parenchyma along with this. This is radical cholecystectomy, and we do see frozen section in our hospital to delineate whether cancer present or not present, or if it's cancer present, how deep it is going, or can we tell that in frozen section slide. Again, sometimes we see as a completion cholecystectomy, revision cholecystectomy, we can see only the lymph nodes and part of the liver parenchyma as a completion cholecystectomy. So this was one example of a gallbladder which was thickened, but slightly smoother on the internal aspect, very irregularly thickened area. This was what it looked like. And to our surprise, with multiple, this is actually one of the frozen section slide. This is completely chronic inflammation and macrophages. So this was chronic inflammation and xanthogranulomatous cholecystitis. It can look like a cancer. It can be very irregular in thickness, but this is where 2 sections at least to be taken at frozen, and obviously many more sections to be taken for paraffin processing. So T stage again for gallbladder is given in textbooks. PT1 usually is invades the lamina propria or muscular layer, and what we are looking for important is PT1B tumor in staging. If we can see definite adenocarcinoma, many of them are actually are papillary in nature, or they will have a lot of proliferation along the mucosal aspect. But if we do see tumor invading and causing fibrous reaction in the muscle cord, that will be PT1B, and that's when the surgeon will remove the local lymph nodes. Tumor restricted only to mucosa may not require local lymph node removal, but any invasion of the muscle cord will require, or surgical standards dictate that local lymph nodes should be removed and part of the liver to be removed. So these are the part of the cancer oncosurgery and for radical cholecystectomy areas. So these are some of the idea is if we are familiar with what is the treatment protocol, depending on our report, we are more alert to understand the implications of, what is PT1A, PT1B, what is PT2, or what is PT3. PT3 is when the tumor perforates the serosa or involves directly invades the liver parenchyma. That's called PT3. So if we know what is the treatment protocol, such as surgery and combined with surgery, we have post-operative chemotherapy, then so on and so forth. Then we understand the implications of or the crucialness of taking the sections and mentioning that in our reports. I think these are just to remind us about we should look at the NCCN guidelines regarding the therapy area or treatment area as well. We do face occult carcinoma of the gallbladder as outside reference slides. Surgically or laparoscopically gallbladder is removed, but as an incidental finding or surprise, we do see a carcinoma. In that setting, what we look for is actually a tumor, presence of tumor. Look for the staging of the tumor, whether it is as far as possible, try to give whether it is PT1, PT1AB, PT2, PT2A. Often we see the tumor extends beyond the muscle coat. We cannot say it is PT2A and PT2B because that depends on the serosal aspect. But at least PT2A is the term I use if the tumor extends beyond the muscle coat of the gallbladder. So these are some of the examples. This is an adenocarcinoma of the gallbladder, and this is what we see. This is the muscle coat, and we see adenocarcinoma beyond the muscle coat in the perimuscular connective tissue. So this will be definitely beyond PT1B. This is at least PT2A, and it's fair to say it is at least PT2A. If we have a liver parenchyma on the external aspect, and if we see tumor cancers glands going into the liver, then we can call it reasonably. I mean, we can call it PT3, but that often is not the case. But often we can see it is beyond the muscle coat, which PT2A is at least a stage. Again, example of PT2A, gallbladder cancer, adenocarcinoma, moderately differentiated. And typically in the revision cholecystectomy, so meaning the gallbladder is removed, we found cancer, and the surgeon has gone back to resect the gallbladder fossa area and the local nodes and the part of the liver parenchyma. Here in this slide, we have on the right side, we have liver parenchyma, which is non-tumorous. And this is an area of the gallbladder fossa area, and we often see foreign body type giant cell reaction, fibrous reaction, patchy inflammation, cholesterol cleft formation. This is what we commonly see. But we do need to sample this area carefully or maybe generously, because we often, along with foreign body type, eosinophilic giant cell, we may see actually cancer. So that's carcinoma at the time of at this place. And that does tell us the staging of the disease. We sometimes see residual cancer, which is just invading the liver parenchyma. So it is important to locate that and stage that so that appropriate further therapy can be given. I think for gallbladder cancer, if it's completely resected with negative cystic cut margin, there is definite survival advantage. That's why radical cholecystectomy and assessment of radical cholecystectomy is so important. Lymph nodes, as many nodes as possible. We have N1 means 1 to 3 nodes. N2 is more than 4 nodes. Again, it is defined what is regional nodes. So celiac or superior mesenteric nodes in the context of CA gallbladder will be taken as N1 nodes. Evaluation of at least 6 nodes is recommended. Some examples of gallbladder carcinoma: we have a muscle coat, we have cancer going onto the perimuscular connective tissue. This is a nice example of I'm seeing some comments here, so I think I'll go ahead. So moderators, are the slides seeing okay? Hello? Hello?
Yes, Kedar, it's perfect.
Yeah, that's okay. Okay, now I'm seeing some messages, and that's why I'm just wondering whether it's seen okay. Yeah, okay. So this is an example of a perineural invasion. Involvement of RA sinuses actually is a very difficult area. What is dysplasia? What is high-grade dysplasia going onto the RA sinus, and what is actually carcinoma? Indeed, it is a difficult area even for experienced histopathologists. And what we look for is actually fibrous area along with the dysplasia in the RA sinuses. I think I'll show you a couple of examples. So this is an example of a gallbladder. We have actually a high-grade dysplasia. We can see the hyperchromasia. We can see the stratification. On the higher power, we actually see a high-grade dysplasia here in the bottom slide. We have a loss of polarity. We have mitotic figures, and we also have some atypical mitotic figures. But this tells us about presence of high-grade dysplasia. This can extend into the RA sinuses. Whether they constitute adenocarcinoma diagnosis, no, this is a difficult matter. Generous sampling and assessment of a fibrous reaction will tell us that. On that, indeed, I confess, is a very difficult diagnosis, and that's why we are fortunate to have a large department, and this is where our experience of our colleagues or informal consultation before I give a diagnosis is actually very important. We grade dysplasia as low grade and high grade dysplasia have stratification, and along with that we have a loss of polarity and atypical mitotic figures. I think I'll go ahead. Going on to the grossing of colorectal carcinoma specimens, this is where I'm going to take about 20 minutes. Essentially, surgery is a treatment of choice in colonic cancers and early rectal cancers. What we need to give is, hello? What we need to give actually is a TNM staging for any adjuvant therapy. Often we are now, or more and more often we are seeing for rectal cancers, we are seeing new adjuvant therapy. And then on biopsy, you prove that it's a cancer. New adjuvant therapy is given, such as chemotherapy and radiation therapy. And then we get a specimen after 6 weeks. The AR surgery, they try to preserve the sphincter as much as possible so as not to have colostomy. So rather than APR, anti-abdominoperitoneal restriction, the surgeons will try to do AR or intrasphincter dissection so that the sphincter is preserved. So these are the ones which we look at. Sometimes we do face a problem in locating the tumor, and often in the rectum, our experience is that 16 to 17 or 18% tumors will show complete response. This is where we have to sample it extensively. We briefly talked about palpation, plaque-like areas, thickened areas. That's what all this is required in the rectal cancer specimen assessment to locate or to prove that there is tumor or there is a complete response. So meticulous pathology examination is important. We'll touch on the lymph node also, because post-CT-RT lymph node number actually reduces. That's where again we have to be as meticulous as possible. So I think I'll go ahead. The report requires us to tell us, is a tumor present? Is it malignant? What is the anatomical extent of the tumor, meaning T stage? What is the lymph node status? Because T and N stage are most important, and the margin is actually important. Usually, our oncosurgeons will look at the margins in the frozen section. So meticulous crossing is a key factor in determining the quality of the subsequent reporting. A little bit on the anatomy aspect. On the left side here, this is a ascending colon, and this is the same diagram will hold true for descending colon. So we have in a ascending colon and descending colon, there's a peritoneal reflection on the anterior aspect, and posteriorly there is no peritoneum, or so that will be our fat, and that will be our actually mesorectal excision. This is where the surgeon will cut on the posterior aspect of the ascending and the descending colon. As against that, the sigmoid colon will have investment of the serosal or peritoneum on all aspects, barring very small area. So sigmoid and transverse colon will have assessment of serosa, or we will take it as PT4. Whereas ascending and descending colon on the posterior aspect, it will be a tumor in this location particularly will be PT3, but it will be sometimes useful or prudent to actually look at if you have a tumor which is circumferential, it could happen that anteriorly we'll have a serosa, so we're looking at PT4 grade, and posteriorly we look at circumferential excision even in ascending and descending colon. Of course, we'll discuss this in much more detail in the rectum. So rectum, we have, this is actually the peritoneal fold in the rectum, which is anteriorly, which is lower down. compared to the posterior aspect. So what we look at, a bare or non-peritonealized area or peritoneal surface, we call it CRM, or circumferential resection margin. The experts in the field for last 15 years have realized that as complete resection of the TME or total mesorectal excision is important for overall prognosis and overall survival. And CRM involvement not only requires adjuvant therapy, but it also directly reduces the overall survival. So assessment of CRM, especially in the rectum posterior part, is actually crucial. So this is a theory or cartoon. I mean, this is a cartoon taken from the FRCPath data sets. On the rectum anteriorly, we have slightly lower down, we have a serosal peritoneal covering, and posteriorly, the peritoneal covering actually higher up. So if we imagine a tumor in the rectum, upper rectum, that has anteriorly serosa, in the mid rectum, it could be actually at the peritoneal reflection above and below, and the lower rectum, typically the tumor does not have any peritoneal covering, so or serosal covering. So this is where we are looking at, if it's a circumferential tumor, we are looking at PT3, but total mesorectal excision, or CRM we are looking at. Posteriorly, even in higher up or in the mid portion, if the tumor is on the postural aspect, there is no serosa. So we are looking at PT3 and we are looking at CRM assessment posteriorly. So anatomical realization of peritoneal reflection in the rectum is actually is very important. I think this is the same thing. And by dictum, we take it that anything more than 1 millimeter is CRM free. Anything less than a millimeter, we call it CRM involved. Or not only tumor, but if there's a positive node which is sitting in the perirectal fatty tissue and which is within a millimeter, then we call it CRM involved. So CRM and serosa are two different things. CRM is actually surgical margin where surgeon knife has gone. It doesn't change the PT3 or PT4. It usually is PT3, but this is important to assess CRM for, this has direct adverse prognostic indicator. Serosa is actually the covering, and this is important in staging because serosa involvement either in stomach, small intestine, or upper part of rectum, or sigmoid or transverse colon, it's actually taken as PT4A. So we just talked about TME or total mesorectal excision, and the surgical guidelines dictate that for rectal cancers, total mesorectal excision is to be done. So a pathology report also should have some comment as, do we see a complete mesorectal excision? So this is what the specimen will look like. These photographs are from the Royal College of Pathologists data set. So if we have a complete plane intact, we call it a good complete TME. If we have a little bit of irregularities, we call it a grade 2 or near complete TME. Or we have a deficiency in the, it's usually called as buttock-like area. If we have deficiency in the fat around the rectum, sometimes the muscularis coat is actually seen. That is an incomplete TME excision, and that is not a good surgical technique. So surgeons are required, oncosurgeons are required to do a complete TME excision. So this is how it will look like. This is, we ink the non-peritonealized surface, we ink with bag, and we cut it as a transverse cut, lay it on the table, and that's where we are trying to look for. So this is from the open anterior aspect. There's a tumor in the rectum here, and this is, I will cut it transverse section. To be honest, this is not completely fixed because we should not see actually any pink areas, but suffices to say that this is what I will lay it on the multiple slices. You lay it on the table and look for the area which is deepest to your CRM, and select a block from this area, this area, this area, this area. So select a block from the area which is going to the deepest, because we need to measure that distance on the slide. These are the slices, and we are looking at deepest area, whether it is going maybe this area which is deepest. But I can see here there's a whitish node in the perirectal fat. So this is what I want to take. This particular section, if I can take completely from the main tumor, I will take it. If it doesn't fit in the entire cassette, I will take this section, but I will keep this black ink on the external aspect intact, because this node, if this is positive histologically and this black ink is less than a millimeter away, then I'll have to call, or we have to call the circumferential resection margin positive. This is how it will look like if you look at these slices. Try to select an area which is maximum deepest, and these two grossly appear to be positive nodes. Take the sections along with a blackish fatty tissue. Don't dissect the nodes separately, because if the nodes are less than a millimeter from the CRM, then the CRM is to be considered positive. So we know this T1, T2, T3, and T4 definitions. These are available in our data sets. PT3 is subserosa or mesorectum, PT2 is a muscle cord, and PT4 is a serosal either involvement or serosal perforation. This is usually in upper rectum or sigmoid colon. Example of actually this is ascending part of the colon, anterior aspect. So this tumor going onto the serosa, not exactly but very close to the serosal aspect. These are the examples from the CRM. So low power view, tumor going, tumor going, tumor going. We have the ink here. This is what I want to look at, whether the tumor cells are on the higher power are very close to this black ink or no. And if they are on the slide less than a millimeter away, we need to consider this CRM as positive. So surgical resection margin, CRM is a very important parameter, prognostic parameter. Generally, longitudinal margin, proximal and distal will not be a problem. Distal will be close, because if the surgeon has tried to preserve the sphincter, as such as in anterior section or intersphincter section, the distal margin is going to be closed, but we can take radial section from that. This chart is an old slide, but it tells us that stage 3 was T4 and N1. The prognosis drastically reduces if we have T4 lesion. So T4 assessment and identification of T4 lesion is actually important. Again, many of the rectal cancers resection specimens are going to be following neoadjuvant therapy. And as we discussed in gastric cancer, we will look at the grading scoring system. So rectal carcinoma, I think we'll go on. These are the areas, this is post-chemotherapy area. So we see a little bit of a depression here, ulcerative lesion, but this is not, this was to start with an ulceroproliferative tumor that has completely gone. So I will take sections 1, 2, 3, 4, 5. So we'll take 4 or 5 sections here, and we'll assess those for presence of residual tumor, and we'll grade those for Mandat grading, 5-point grading or 4-point grading, and so on and so forth. We also look at the distal margin here. The margin here seems to be all right here, so that's this particular case. So again, a high power view of this closer view of the ulcer or scar area, and here I've personally found the palpation gives rise to, because often there is a fibrotic reaction, the palpation gives rise to an irregular thickening in this area or plaque-like area, and this is where we should be taking sections from. So again, just as we saw in gastric cancer specimens, we are looking at, microscopy shows us fibrosis, hemorrhage, necrosis, inflammation, and acellular mucin, again, are not counted as tumor. It is called as YPT0. And lymph nodes, again, lymph nodes also with acellular mucin are also considered YPN0. They are not considered as metastatic nodes. So this is an example where there was a tumor, but there's a lot of fibrous reaction in the wall here. So this is rather whitish, or it could look a bit yellowish rather than a tumor. Anything which looks, fleshy area, the fish flesh appearance, that is the time where we are looking for sectioning as much more. If we, to be honest, if we have a tumor, or even one section is enough, one optimum section is enough for us to give proper staging. But if we don't have tumor, that's when we require more sections, 4, 5, 6 sections. We need to examine deep cuts to give the proper the tumor regression grading score. So this is an example of a acellular mucin in the wall of the tumor, and that's again taken as no tumor present. So TRG, or tumor regression grade, as we saw earlier, initially given by Dorok in 5-point system. We are still using that, but it was essentially a Mandat system which was used in esophagus. We are still continuing to use it in the rectum, but that's because it's our practice has been the consistent, uniform, and our clinical colleagues are used to that. But CAP does tell us that to use a more simpler system, 3-point or 4-point system. I think this is an example of a mandate 5-point that we are using in our department, 5-point system. 1 being no tumor and 5 being very little effect on the tumor, so extensive tumor present, whereas we can have 3-point score system, 1, 2, or 3 or 4-point system. So this is an example of PRG score 3 out of 5 or 2 out of 3. We have some tumor cells in the muscle coat here, so it could be actually YPT2. But much of the tumor, or at least a sizable part of the tumor, has been killed by the chemotherapy and radiation therapy. So definitions of PN stage exist. N1 is N1A, 1 node, N1B, 2 to 3 nodes, and there is N1C. We'll look at this thing in the next 5 to 10 minutes. What is N1C, and we have what is N2 and N2B. These definitions exist. So coming to the nodes, basically nodes are along the blood vessels that supply the colon and the rectum. They are N1 and N2 depending on the number involved. We have the definitions available in minimum data sets. So in perirectal lymph nodes, they include lateral sacral, presacral, sacral, promontory, middle rectal. Normally, rectum contains lesser number of nodes in the perirectal fat as compared to the colon. So colon will have typically more number of nodes. So how many nodes to submit? Submission of all the nodes are required in cancer specimen, may it be rectum or colon. The accuracy and predictive value of stage 2 assignment are directly proportional to the thoroughness of the surgical techniques in removing all the regional nodes. So surgeon has to do a complete diligent job in removing all the fat around the colon, and pathologist has to dissect all the nodes, dissect very meticulously, because these two are the alterable factors. The age of the patient is not alterable factor. Preoperative therapy is not the alterable factor, but the factors regarding surgical technique and careful dissection by the pathologist are two important alterable factors. So we need to have 12 nodes definitely for a colorectal cancer specimen. This is the guideline. The guideline came in 2007, and we need to find 12 nodes. If we have less than 12 nodes, our guidelines mention or state that we should go back to the specimen, try to dissect more number of nodes, and then try to see if we have any further nodes. It is possible that we may find, even after doing that, it is possible that we may come across less than 12 nodes. But a vigorous attempt on our part is required. Typically, in post CTRT, we will have less number of nodes, but we should be as close to 12 as possible, and we should be actually revisiting the specimen also. I think we just mentioned that the surgical diligence and the skill of the pathologist are actually two important factors. So this brings us to our small effort. Long back, we looked at our about 170 specimens. This is a 10-year-old data. Are we achieving the benchmark of retrieving 12 nodes in colorectal cancer specimens? And from our audit, we saw 120 colorectal carcinoma specimens. Mean yield, lymph node yield was 12.68 and median was 11. Rectal cancer mean was 10.3. So as expected, rectal cancers have generally lesser number of nodes as compared to colon cancer specimens. So mean in colon was 16, whereas in rectum was 10. Overall mean was 12, and overall lymph node positivity in those specimens was 44%. So I think we'll skip these. These are the tables, detailed tables from the article itself. So what did we learn from this? We learned that if we relook cross examination is done, this needs to be mentioned in the report because that's mentioned in our data sets. This has not been our consistent practice. So after this audit 10 years ago, we started mentioning in our report, okay, we found 8 nodes, but we went back and we took 4 extra sections, we found 2 more nodes. So we started mentioning that in our report. Our mean was more than 12, but the more the merrier is the dictum in this field. Retrieval of lymph nodes need no high-end machines, no high resource techniques or dissolving techniques. What it requires is actually a good H&E and a careful dissection on the part of the pathologist. So this prompted us to do the similar audit again after 2 years, and our Saurav Sarkar, our MD student, who's actually a consultant pathologist at Kolkata now, did an audit, did a dissertation, which is a beautiful audit and dissertation. And we looked at, again, histopathology reports of colorectal cancer, an audit of 3 years. And what did we find? We found, I think I'll skip these slides. So a total of 393 cases of colorectal cancer surgery. We looked at the reports, and we tabulated, how many nodes, how many positive. Did we mention all the compliance of our data sets regarding T stage, N stage, perineural invasion, LVI, and so on and so forth. I'll go on. These are the contents of this publication. I'll go on to the last slide. So essentially, the surgeries were of variety of types: APR, AR, low AR or anterior section, ultra low AR, intersphincter dissections. Some of the surgeries were pelvic excenteration, left hemicolectomy, right hemicolectomy, proctocolectomy, sigmoidcolectomy, transverse colectomy, and so on and so forth. So total 393 reports were checked. And if we come to the last summary or conclusion slide of this particular audit, we found that the mean age was 53, mean lymph node yield compared with all colorectum was 16, median was 15. Overall lymph node positivity was 42%. So if we refer to our previous audit, which was 3 years old, that overall positivity was 44%. So this is somewhat similar. There was no statistically significant difference between the mean lymph node harvest in the age group. So if you try to say anything less than 40 or more than 40, there was no significant difference. But there was statistically significant difference between the mean lymph node yield from specimen of rectal cancers, which was 13, and from specimen of colonic cancer, which was 23. And there was also statistically significant difference between the mean lymph node yield in chemo-radio naive cases, which is 22, and in neoadjuvant therapy cases, which was 12. So by this, I mean that all these cases, we have, this 12 is after a lot of hard work in trying to dissect the dissection. But in some cases, I will admit that even despite going back to the specimen in post-chemo radio cases, our lymph node mean number is less than 12. But the point I'm trying to make is that try to look for nodes diligently so that we try to reach the 12 node in especially post-chemotherapy cases. As I said earlier, the fat dissolving techniques are available, but it's time-consuming and needs expertise, and feasibility in laboratory handling high volume is actually really questionable. So this is an example of again same thing that we saw earlier. A little bit of 2 or 3 slides on what is N1C. This is I've taken it from the AJCC Cancer Staging Manual, which is the 8th edition, and this is a 5-year-old textbook, but this is still the recent one. The tumor deposit is a discrete nodule of cancer, which is in pericolic or perirectal fat or adjacent mesentery, and within the lymph node drainage area of the primary carcinoma, without identifiable lymph node tissue or identifiable vascular structure. The shape, contour, or size is not considered in this designation. So if we see a vessel, if we see lymphatic invasion, if we see perineural invasion, those are called as V plus or L plus. So they are not called as tumor deposit. So a tumor deposit, we have to see a tumor deposit in the lymph node drainage area, and the size, because why I'm saying this, that TNM5 did give a definition of 3 millimeter size for such a deposit. So TNM8 or 7 or 8 does not give that deposit. So this is a tumor deposit, and these are the ones which we need to identify separate from the lymph nodes or metastatic nodes, and they are called as N1C staging. So we know that even if, say, suppose, for example, theoretically, I find 10 nodes which are negative, and I see a tumor deposit which does not have a lymph node contour, I can't call it N0, I will call it N1C. That's what actually it means. And experts in the field have found that this has a poor survival, overall survival. So the textbook tells us that approximately 10% of primary colon or rectal cancers have tumor deposits, and 2.5% of colonic and 3.3% of rectal cancers can have these tumor deposits. So what we call tumor deposits are important. Textbooks give us that. We'll have maybe some discussion on that in question answers. The textbooks also tells us that number of tumor deposits is not added to the number of positive regional lymph nodes if one or more lymph nodes contain cancer. And here I think I will confess that sometimes practically I have counted those in total number of nodes, in the sense we have, say, 2 nodes which are positive out of, say, 14. And if we have one or 2 or 3 tumor deposits, I have used in the report that, okay, we have 2 positive nodes and 2 further tumor deposits. So best regarded as N2A disease or N2B disease, and depending on the number. So I've confessed that I've done that. The textbooks say that strictly speaking, we should identify those separately and should not club it with the nodes. But this is something remains a practicality point, and our oncologist, tumor deposit, even though the nodes are negative, and N1C disease is going to receive chemotherapy post-operatively. So this is a point, I would say, a relatively gray area. But for practical point of view, they are considered as they will be considered treated as positive nodes by the medical oncologist. We define what is micrometastasis or isolated tumor cells, and there's a definition or labels on that. Last point, I think it is challenging to distinguish what is actually a tumor deposit, and in the treated cancer case by CT and RT, what is a part of the tumor which has responded to neoadjuvant therapy. So suppose, example, we have 3 centimeter tumor before CT-RT, and the tumor has partially responded. That means that 3 centimeter becomes 2 small separate areas of 1 centimeter each. Does that mean that's a tumor deposit, or this is a tumor area? This again is a very challenging to distinguish between whether it's a node or tumor. I mean, by and large, in the area of tumor, we call it a tumor, and depending on the size or location, we call it a T1, T2, or T3, why PT1 or PT1, PT2 or PT3. I think that's probably also to conclude regarding the colorectal cancer specimen. Distal colonic location, small tumor volume, and early stage are some of the non-alterable factors. But what are the alterable factors in lymph node dissection? And a good report is surgical expertise and diligence of the pathologist. So if we remember that our importance and our expertise are required, our diligence is actually required. As many nodes as possible to be examined for good TNM staging, and neoadjuvant or preoperative radiation therapy can yield in less number of nodes. That we have to understand, but we try to go as close to 12 figure as possible. I think I'll stop at that. I must thank Dr. Mukhtar Amadwar, my senior pathology colleagues, and who was our SR, Dr. Shubhashri Dash, who was our SR, and who did DM oncopathology research and is back to Orissa, who have helped me in preparation of the slides. I think I'll stop at that. Okay, sorry.
Hi, Kedar.
So, right. I think I'll stop at that. We can take the questions, please. Yeah.
So the question is,
Sure.
make out Brunner.
Sorry, I didn't get that. Yeah. How do you
make out Brunner gland hyperplasia?
Brunner hyperplasia.
How do you make out hyperplasia of?
So how do we make out Brunner's gland
Brunner's
hyperplasia?
See, if you are looking at the biopsy from the first or second part of the duodenum, which says that there's a nodularity, because to call something hyperplasia, you need to know what is normal thickness of Brunner's gland, and that is a completely variable point. So, so to give accurate answer is actually difficult. But if the endoscopist has felt a nodularity, and if we see many number of Brunner's gland, this is a diagnosis one can give. Of course, we have to exclude more important factors such as any dysplasia, or if there's a finding of H. pylori or any other giardia or something, so on and so forth. So Brunner gland hyperplasia is relatively subjective diagnosis. But if it's seen as an endoscopic abnormality, this can be given as Brunner gland hyperplasia. Mind you, some people use the term Brunner gland hematomatous expansion, and that's also, you can't debate with that. But Brunner gland hyperplasia is I think endoscopically visible abnormality, and you see only the Brunner's gland in very large numbers, but no other pathology. Then we can give this diagnosis.
So there's another question. Why stomach specimen is cut from the greater curvature?
That is a standard practice. It's nothing hard and fast in that. Many times we have a tumor on the lesser curvature or anterior or posterior wall. It is somewhat easier to cut it from the greater curvature, and also easier to keep the orientation after cutting from the greater curvature. So this is just a dictum and not a hard and fast rule, because if you have the tumor in that location, we will cut it in the opposite direction.
Thank you, sir, for the explanation. So there's another question, sir. Can we differentiate metastatic nodes and normal ones in gross examination?
Metastatic node and
Normal one.
Normal node. Yeah, I think we can have a fair idea. Actually, metastatic nodes, first and foremost, my feeling is that they are actually firmer to hard in consistency. If we feel, even if the node is smaller in size, if it's firm, and if it's not gritty to cut to, what I mean by that is it's not calcified node. It is likely to be the first is a firm to hard feel, and secondly, whitish or grayish appearance is actually metastatic suspicion is high. The normal node would be rather tan or brownish in color rather than whitish in color. But of course, we will confirm that with histopathology. But this is what the two things I will combine to suspect a metastatic node.
So we have another
Sir,
question.
another question is,
Sure. Yeah,
what
so there
the
might be
stage will tumor extending into lesser omentum or greater omentum?
lesser omentum we will not be able to know, because lesser omentum is a something which is a surgeon knows while he is resecting. Lesser omentum is not something that we receive as a tissue. Lesser omentum is an area. So what we can, from our specimen point of view, we can only say perigastric adipose tissue involvement or no. So that is PT3 or PT2. Greater omentum, yes, we will again see perigastric involvement, but stomach, mind you, stomach in this area will have the serosa. So involvement of greater omentum can also signify, or so we need to section it properly so that we can get judgment of PT3 or PT4. Serosal involvement being PT4A stage.
Sir, can H be seen on routine?
Yes,
HI
it can be seen actually.
study not available. Yeah, we are.
Yes, so you can see it. You know that because if I have a active inflammation without any ulceration in the gastric mucosa, I will look harder for H. pylori, and you know that on the mucosal surface in the foveolar area or foveolar pits, and they will be seen. I think it's not mandatory to use special stains for H. pylori. I mean, that's my personal opinion. Gimsa or Vardin Stari, people have used different stains to delineate it better, but they can be seen, and if they are larger in number or reasonable in number, I think you can report in on H&E also. The problem, I mean, the difficulty will come is that if they are very few in number, then you would want to do a Gimsa or some other stain to prove that they are there, and then actually then it's a better idea to because sometimes patient may have taken a partial treatment, and that's the time when you will see fewer in number. So in that case, it's better to use special stain of whatever is available of your choice. But if you say they are seen on H&E, I will not debate with you. They can be seen, and it is fine to report that.
Okay, sir. If we have a post-NACT specimen with small 2 centimeter size tumor at cardia, epicenter 1 centimeter,
Yes, gastroesophageal junction. Yeah.
Not involving the esophagus. Gastroesophageal junction. Do we still stage it as per esophageal cancer?
Important question, because the guidelines say that from the gastroesophageal junction, less than 2 centimeter will take it as esophageal cancer, and more than 2 centimeter epicenter will take it as a proximal gastric cancer. Here, I think the question is actually difficult to answer because, but we have to understand that we are looking at the post-chemotherapy case. So here, I think I will rely on the endoscopy or preoperative chemotherapy, preoperative CT scan. If we can say, if we that report says that there is no 3 centimeter or 4 centimeter lesion in the proximal stomach or cardia, then I will stage, even though we see 1 centimeter tumor from the CO junction, I will still call it a CA stomach, or stage it as per the cancer stomach guideline. Because this is something which we are seeing as a smaller volume tumor post chemotherapy. So let us be guided by the chemo naive patient or finding, and we'll take that from that.
What are the microscopic changes seen after post-NSCT?
It could be variable. Usually we see, a mild fibrous reaction. We often see microcalcification, and we often see foamy macrophage aggregation. We see that in GI tract, but we often, or more often, we see that in ovaries. But in GI tract, other point, what we see is actually acellular mucin. So a mild fibrous reaction, calcification, and acellular mucin are the ones which we see in stomach and the rectum.
Okay, sir.
Yeah.
What to fit positive nodes tumor deposits in end stage in colon carcinoma?
Sorry, come again.
To fit
Yes.
positives in end
Yes.
node
So
stage in colon carcinoma.
yeah, this is an important question, but there is a gray area amongst some experts. We should actually mention how many nodes are positive. So first and foremost, we have to understand that any positive node requires post-operative chemotherapy. So the patient may have had pre-operative chemotherapy, that's a different matter. But any positive node makes it into stage 3 directly, whether it is a node positive or a tumor deposit as N1C. Now, as regards to counting and giving end stage, I just actually briefly touched on that. We should give the identifiable nodes. Say, suppose I have 10 nodes and 2 of them are positive. I will say 2 out of 10 nodes show metastatic adenocarcinoma without perinodal extension. In addition, we have 2 tumor deposits. These are the ones which I don't identify any nodal structure, nor there any nodal contour, and I don't see any vessel or nerve or any other relation with that. So this is how we try to distinguish between tumor deposit and node. But to be honest, as a final point from and this, I think I will discuss with your treating oncologist or medical oncologist. But by and large, practical point of view, if you have 2 nodes positive and if you have 2 tumor deposits, the medical oncologist overall will take it as 4 positive nodes. But do you please discuss that? You have to discuss that with your medical oncologist. That's the practical reality to count. So you may end up saying that best regarded as PT and PT to N2 disease, something like that.
Okay. Does it mean if we are calling a foci as tumor deposit, there shouldn't be any vascular structures or
Yes.
nerves identified
Yes.
within the nodule?
Yes, there should not be any vascular structure or neural structure. It should be in a lymph node drainage area, but without any vessel or nerve or any identifiable nodal structure. Those are the ones which are called as tumor deposits, and they will be staged as PT N1C if we don't have any other positive nodes. Those are N1C disease.
Okay, sir. Ascending colon is retroperitoneal or intraperitoneal?
Ascending colon on the anterior aspect has serosal covering. So descending colon also has peritoneum on the anterior aspect. So, and posteriorly, there is obviously no serosa, there's only the fat. So imagine if you have a tumor in the ascending colon, which is circumferential, when you open it, the part of the tumor will have serosal covering on the anterior surface. So identify the sections in such a way that you have a tumor section with the deepest infiltration, which may be close to serosa, because that will determine your PT4A staging. And posteriorly, try to see the fat or pericolic fat and try to ink that area so that you can that doesn't change PT3 or PT4 stage, but that can give us some idea as to CRM positive or negative in the posterior aspect of the ascending colon. So posterior part is retroperitoneal. Yes.
Okay, sir. How to avoid reporting false negative marks in section in cases of poorly cohesive carcinoma of stomach, as
Yes.
sometimes identifying signet ring cells are very difficult on frozen.
Yes. So I agree with you. Sometimes it is difficult, and if we do actually audit of our frozen section report, it is not 100% perfect. So meaning you will have some cases where I have called it negative for malignancy or negative for tumor cells. And on paraffin section, we may see a few tumor cells in the margin. So here, what is important, whether we have taken a margin which is radial or shear margin. A radial margin will still give us a chance to say, okay, even though in the section there are tumor cells, the inked margin is negative. But if it's a shear margin, it can happen that we will see tumor cells so these are frozen section negative report, paraffin section positive report. What I can say that this remains a discrepancy in the report, but especially in poorly cohesive carcinomas, because they are known to have kind of a skip lesions. It is known, so surgeon knows that this thing is possible, but in the overall context, if the nodes are positive, then this only this particular finding of margin positivity does not have that adverse connotation, because the overall prognosis will be determined by the positive nodes.
Okay, sir. Thank you, sir. Positive omental deposits in colorectal cancer, is it
Yes.
considered as M1?
I don't know for sure, but I think it is for M1. I think it is M1. I will confess to you, I don't know the full answer to that, because we rarely face a situation omental deposit. If it's not, it is usually what happens is when the surgeon starts operating, if he has a mesenteric deposit or a omental deposit, they first of all take that sample, send it for frozen. If it's taken as metastatic disease, the primary surgery is abandoned. So I think my judgment is that it is an M1 disease. Yes.
Okay, sir. Thank you, sir. Can IgG4 related disease be encountered in gallbladder or duodenum?
Gallbladder, yes. Duodenum, I have not personally seen so, but gallbladder, yes.
Okay, sir. Which system to use in complete regression case with positive nodes?
We are using this 5-grade system, which is mandated scoring system. So complete regression will be YPT0, but you just mentioned that the nodes is showing metastatic carcinoma. So YPT0, what I mean is TNM stage, YPT0, N1 or N1A or whatever. As regards to TRG scoring, if the primary TRG mainly is related to the primary tumor. So primary tumor TRG scaring will be actually grade 1 or no residual tumor. But TNM, obviously, we should point out in that report that TNM end stage is N+. TRG is for primary and TNM stage for tumor as well as nodes. So that will be the primary tumor is complete regression, but it is possible that the nodes are positive. Sometimes we do face this situation in gallbladder also. So no residual disease, but nodes are positive.
Okay, sir. No positive, but no residual cancer regional site. What report?
Again, we just said that so T stage will be YPT0, but the nodes are positive, meaning they are showing adenocarcinoma cells metastatic in the node, then we'll have to report it as YN1A or N1B or so on. TRG can be given as TRG, no residual disease.
Okay, sir.
Yeah.
Will PAS help in detecting scant signet ring cell deposit momentum?
Will what?
PAS and PS.
PA we don't use for actually momentum. So you are looking for momentum metastatic adenocarcinoma, which is resected along with the stomach, or you are looking at the biopsy?
I think it
So along with the
be
stomach,
resected
PS
along
is
with.
helpful. But if you really are worried about being a metastatic focus, first I will look for a fibrotic reaction around that particular area where you are suspecting a metastatic a group of metastatic cells. PS is useful, but if you have the facility, it's better to use immunohistochemistry to delineate epithelial cells in that. Because there's a technical possibility that you have a mucin or mucus and then PS may be positive. So fibrous reaction and immunohistochemistry with cytokeratin is actually better for looking for metastasis in momentum.
Okay, sir. If 3 lymph nodes positive and 1 tumor deposit, is there, should we report it as N2 in colorectal cancer?
Yeah, I think what we can do, I think we just discussed about it. I think what we can do is we can mention specifically in our text of the report that there are 3 metastatic nodes and there is 1 tumor. In addition, there is 1 tumor deposit. And in brackets, we can write a comment that this may be taken as N2 disease. Because practically, I think we can club it. That's my personal opinion. And my personal opinion is based on actually our TNM5 guidelines. So there is some merit in saying that. But strictly speaking, current guidelines ask us to report those separately.
Okay, sir. When do we say a complete pathological response for colonic cancer with neoadjuvant therapy specimen?
Colonic cancer receiving neoadjuvant therapy is actually uncommon. We usually see that in rectal cancers, but colonic cancer, if receives neoadjuvant therapy, we have to corroborate with our preoperative CT scan or endoscopy what is the location of the tumor. And I will sample very generously regarding the primary area, at least 5 to 6 sections. Sometimes the section is not phased properly. I will do deep cut on that, and then only I will say no residual tumor in that. We may see acellular mucin, and that's regarded as no residual tumor. But a generous sample, especially to call it no residual tumor, is required.
Okay. Are there any cutoff of site-specific lymph node yield in GI cancers post NACT?
No, I mean, so for colorectum, minimum 12 are required. For gallbladder, 6 are required. And for stomach, at least 15, 16 are required. We understand that post-chemotherapy, the number is going to be low. But our attempt will be to try and regross and try as close to the prescribed number as possible. And we should mention that in our report that regrossing is done and extra sections do not yield any additional nodes or yield 2 small additional reactive nodes, something like that.
Kedar, questions will keep on coming if you keep on answering.
Okay.
The delegates are enjoying. We still have a house full for you. So there are a few more questions. Are you ready to take them?
Yeah, I'm ready. Maybe we can take few more. Yeah, that's fine.
Okay,
Yeah.
Go ahead.
2 questions left. Many times we get colonoscopic biopsies for malignant growth, but biopsy is superficial only. No muscularis layer identified.
Yes.
How to report?
Muscularis, I mean, for endoscopic biopsy, we won't get muscle coat. We will get only mucosa and maybe part of submucosa. But your question is actually very valid. Because our practice in assessing a biopsy is to look at patient's endoscopy and CT scan report also when we are looking at the biopsy. And if there is a discrepancy, sometimes what we'll see is that superficial biopsy gives us a lot of ulceration, exudate, maybe a few dysplastic cells, in which case we should mention that first of all, we should mention what we see. In that, I will say that histology mainly shows acute inflammatory exudate, and there are a few groups of cells which show moderate dysplasia. But here, I think I will, here again, our medical knowledge, surgical knowledge, gynae knowledge will come in, and we should take a note, we should write a note or comment in our report that in view of the endoscopically suspicion lesion of or suspicion malignancy, a rebiopsy is recommended.
Okay, sir.
I think,
How many
okay.
in post-NSCT cases?
How many sections should be taken in post-NSCT cases in which organ?
How many minimum sections?
Minimum sections.
to be
I think
taken?
minimum should be 4. We I think please be
Colorectal.
guided here by the area of abnormality. But minimum 4 should be taken, and I think not only stop at 4 sections, do deep cuts on that to check whether there is small focus of tumor cells lying in between any muscle coat or submucosa. But 6 will be a better number, but minimum 4 should be better if we are calling no cancer, no residual cancer.
Okay, sir.
I think Kedar, great presentation, and there's so many questions coming up. But I think there is a lot of compliments for you.
No, thank you. I think it's very practical, and I must confess there are again gray areas. So it's not that we have all the answers, but I think the questions were spot on. But this is what I think we learn from our multidisciplinary team aspects. So these are some of the clues that we get from from our knowledge from medical oncology as how they treat that, and that gives us what to write in our report. Yeah.
So my colleagues, Shalini, do you have any comments, or has Dr. Bilal joined? Dr. Bilal, are you there? If you are there, you can switch on your video, Dr. Bilal. I can't see you.
Yeah, you can see me now. Hi, sir.
Bilal, yes.
Bilal, hi, good evening, hi.
How are you?
Good evening,
Good to
sir.
see you.
Nice, thanks. Sorry, I was busy this time, so I just missed your this lecture. sir.
No, that's perfectly fine. Nice to see you, Dr. Bilal. Yeah.
Yeah, we are long back. We just saw Dr. Kedar. I mean, 2013, I think. It's
Yes.
1 decade. We have just, And
Yeah.
thanks to Dr. Gujral,
Yes.
just he has just made me and to get to see all nice people.
That's right.
We thought we'll have a little more time with you, but I'm not going to leave you. I'll have you next session sometime. Bilal, you can't run away.
Nice, sir. Anytime,
Yes.
pleasure, my pleasure. sir.
Thank you, Bilal. Shalini, Dr. Bilal, you want to say something to students, or are you okay?
Regarding it was the about the GI cancers, regarding post-NAT and all those things. So definitely there are some things. I mean, we also experience in our practice. I mean, the clinicians are not happy, the endoscopists are not happy. I mean, sometimes there is a clear-cut growth in the colon or stomach, and the representative biopsy is not being taken. So Dr. Kedar very well said that we always put a note, because when we see that clinically and radiologically the lesion is there, I mean it is mitotic lesion there, but most of the clinicians think that the pathologists are the angels. They are not the angels. I mean your patient is your slide. So
Yes.
whatever slide speaks, you have to speak that on. Although
Yeah.
the patient may have some different story also there.
Yeah,
on
I
the other
agree.
side.
Completely, I agree. One more thing
So,
actually
I
we
have
can
lot
do
of
is that.
che-
Sorry, one more thing we can do is that before we say this is only superficial biopsy, we recommend rebiopsy. I do try a deep cut on that, just from my point of
Right.
view, audit point of view, that I'm not missing any
Right.
lesion in the
Yeah,
deeper cut. So
100%.
that
We
also,
always check the wax block. We see
True.
whether all the tissue bits, whatever we have grasped, 6 or 7 bits of the same size, 1 mm, 2 mm, they are on the slide or not.
absolutely.
So if
And-
we are pretty sure that the slide and the block matches, then we write the note that in view of the strong clinico-endoscopic suspicion of mitotic lesion, a repeat representative biopsy is desired.
Perfect.
We always
Perfect.
put that note.
I have the same practice.
So that also helps us, because sometimes I have seen a case in stomach, at least 3 endoscopies, 3 biopsies were done, 3 were inconclusive. And after 4th biopsy was taken, it proved to be malignant.
Yeah, agree.
So
Completely
these are
agree.
the really some things we have to think also, and to benefit the patient in that.
Yeah.
Thank you, Dr. Bilal.
And also there is one thing again about the omental and the deposit. I mean, when we are dissecting the nodes in the colorectal cancers, so we always sometimes, because particularly in TME specimen, so you have a lot of extranodal extensions, and there is a lot of lymphovascular invasion. So that lymphovascular invasion and some extranodal extension sometimes peeps up into the adjacent mesentery, and you are not able to judge whether it is a lymphatic lymph node spread or it is an extranodal extension. So, but if you have to speak, because the question was there that whether we will count it as a node or we will count it as a mesenteric deposit. So in that way, most of the times the node, you have some sort of lymphoid remnant or the capsule in the side.
Yes.
So in that way, you can put it as a node. If there is nothing, a capsule, no lymphoid remnant is there, and it's a dispersed way, the tumor is in the fat and fibrous tissue. So in that way, you can take as an extranodal extension or extravascular extension.
Yeah. Agree. Totally agree.
That is also there.
Thank you very much, Dr. Bilal. Shalini, you have any comments or any questions for sir, or anything you want to say?
Sir, thanks a lot, sir, for all the great information he has given us, sir. It was a great learning for us.
You are there. Dr. Debarati, you want to say something? You're okay otherwise. So Kedar, any final comments?
No, I'm okay. Thank you all, because